Good morning, respected teachers. Uh, Today we have a 62-year-old gentleman, resident of Jhunjhunu, Rajasthan, grocery shop manager by profession. He's married and was admitted on 23rd of September at our institution, SDMH Jaipur, with the chief complaints of recurrent episodes of fever, post laparoscopic cholecystectomy done on 12th September, along with yellowish discoloration of urine and sclera from 7 days post surgery. We go back to his history prior to the surgery. He was apparently well 5 months ago, had recurrent episodes of dull aching pain in the uh, upper abdomen for the last 5 months. His pain was associated with nausea and occasional episodes of non-bilious vomiting, which increased postprandially on intake of fatty foods. There was no history of radiation of pain. Neither there was any history of yellowish discoloration of urine or sclera prior to the surgery. There was no history of fever also prior to the surgery. He was subsequently investigated with ultrasonography and was found to have gallbladder stones. He underwent laparoscopic cholecystectomy elsewhere on 12th of September. His intraoperative time was 1 hour approximately as reported by the patient relatives. No drain was placed. Here I would like to know the intraoperative notes and the histopathology report, which are still not available. The patient made an apparently uneventful recovery till postoperative day 2. However, he complained of mild increase in pain intensity over the right upper abdomen. He had high-grade fever episodes of the order of 102 to 103 degree Fahrenheit from the evening of postoperative day 3, which was associated with chills and rigor, but he had no associated history of difficulty in breathing, cough, or burning sensation during micturition. His fever subsided with oral medications, and he had 2 to 3 episodes per day till the postoperative day 12. His fever intensity and frequency gradually decreased following placement of an ultrasound guided intra-abdominal drain on POD 12. He also noticed yellowish discoloration of the urine followed by yellowish discoloration of sclera from 5 days after the surgery. But there was no history of gradual deepening of this yellowish discoloration. Neither there was any history of clay-colored stools or any history of generalized pruritus. It was associated with loss of appetite for the same duration. He also had no history of nausea and vomiting during the postoperative period. Neither he has any history of abdominal distension. He was passing flatus and passed motion every alternate day on administration of enema. He underwent an ultrasound guided intra-abdominal drain placement on 24th of September, that is the POD 12, which drained initially dirty purulent material followed by drainage of clear greenish bilious fluid around 150 ml per day, which later decreased to 30 ml per day following an endoscopic procedure. This was associated with improvement in appetite with abatement of fever episodes after the placement of the drain. He also underwent an endoscopic procedure on 27th of September, which was the postoperative day 15. Among past illness, family history and personal history, he has no known comorbidities, no past history of surgery. His family history is non-contributory. He takes a vegetarian diet. Bowel and bladder habits prior to surgery were normal, and he has no history of addiction or drug abuse. Shall I summarize my history, sir?
Yeah, please do, and then we'll ask you.
Yes, sir. 60-year-old male with no known comorbidities presents with recurrent high-grade fever episodes and yellowish distillation of sclera and urine, along with loss of appetite post-laparoscopic cholecystectomy on 12th September for recurrent biliary colic, which subsided on placement of intra-abdominal drain and an endoscopic procedure, which most likely is an ERCP.
In the pre-op history, like you said, there's a recurrent biliary colic.
Yes, sir.
But in the history, you did not say it was a recurrent biliary colic. It's a dull aching pain or some sort of. How do you qualify his presentation before surgery?
Sir, he complained of upper abdominal pain for about 5 months prior to the surgery, without any history of radiation. It increased postprandial and intake of foods. There was no associated fever or yellowish discharge of urine or
There was
sputum
only
prior to the
one episode of pain before surgery, 5 months before surgery, you said.
No, sir. He
There
had
was only
multiple
episode.
episodes. He had multiple episodes, sir.
Okay. Any history of jaundice before surgery? Would you
No,
like to
sir.
know?
No, sir. He had no
Surgery.
history of jaundice prior to the surgery.
Okay. I think the summary basically you have to mention these are the things you have to highlight. One is state of surgery, I mean his symptoms, whether there is history of jaundice, and then of course intraoperative any event that you have to qualify in the surgery itself because this has happened immediately post surgery.
Yes, sir.
So how was the surgery and was there any complication? I mean that you mentioned in the presentation, but in the summary also you can add this is an uneventful cholecystectomy, apparently uneventful cholecystectomy, following
Yes, sir.
which he presented with whatever I said. So
Yes, sir.
what are the likely possibilities like you can think of?
Sir, I would
Yeah, please do.
sir, so I would like to keep in my provisional diagnosis first as a post-cholecystectomy bile leak, followed by with or without a hollow viscous injury, probably a duodenal injury. These are the two possibilities I would like to keep in my mind as my provisional diagnosis.
Would you entertain duodenal injury here? Why do you say so?
Sir, he had no. He was apparently making an uneventful recovery till POD 3. By POD 3, he
No,
was
what I mean
having.
to say somebody with a duodenal injury would he last that long, 10 day, 14 day you have intervened? Would he continue to have? So it is very unlikely. I mean, if it has detected immediately after surgery, there is a bilious fluid in the drain immediately after surgery, then you could have think of this.
Yes,
I
sir.
could have thought of this. But point is, he continued for at least 8 days, 10 days before you intervene, whatever sound and what in whatever form. So duodenal injury, is highly unlikely in this setting, this kind of setting. Biliary injury, fine. Bile leak is okay, but I don't think you'll have to bring in duodenal injury here, unless it was an immediate. Yeah, please.
Yeah. The thing is, why don't you suspect a CVD stone with cystic that blowout?
Sir, that might be a possibility, sir, but it
Yeah,
eventually will
that
lead to.
should be quite an early possibility because he underwent a laparoscopic cholecystectomy, then developed jaundice, and then he developed the bile leak, which was detected on the ultrasound. So you should
Yes, sir.
definitely consider that as one of the differential diagnoses. The older the person, the more likely it is. And also, you mentioned pruritus only as generalized pruritus. It is
Yes, sir.
important to remember that pruritus may not be generalized. It is restricted to the trunk mainly, usually back and abdomen, and then as the jaundice deepens, it spreads to the rest of the body.
Yes, sir.
Yeah. So now can you modify your presentation? Like what are the post-op events you thought would have happened?
Sir, post-cholecystectomy bile leak might be due to missed CVD stone, which causes a cystic duct stump blowout. Other possibilities might be due to improper slippage of the clips due to improper placement or ischemic necrosis of the cystic duct stump or slippage of the clips.
Why not injury to the bile duct?
Sir, it might.
I mean,
It
looking
also,
at the complete history
yes, sir,
of post-op
it can
events as well as
also
the
be caused
intervention.
by, yes, sir. It can also be caused by a diathermy or a injury to the CVD because the patient gives a history of discharge of greenish bilious fluid from the drain, which was placed intra-abdominal later. So it most likely is a drainage from the CVD unit.
So even if you think it's a bile leak, what kind of bile leak it would be? It would be from the cut end of the CBD or it's a lateral leak or it's a, what do you think would it, is the possibility?
Sir, I would consider a lateral injury and a cystic stump blowout. It is difficult to exactly pinpoint which might be occurring. A complete
Why do you
transaction
say
of
lateral
CBD.
injury? Fine, we understand it's lateral injury, but why do you say it's the lateral injury in view of the history you have got?
Sir, he was not having, even after drain placement, he was not having that much amount of biliary leak. It was only about 150 ml per day. Was draining greenish bile, frankly greenish bile, sorry. In case of a complete transaction of CBD, the output would have been much more. Also, the patient is
No,
not
I think
having
the
any.
single point, you are missing the point here because he has a history of therapeutic intervention, endoscopic therapeutic
Yes,
intervention.
sir.
That
That
will only
itself
happen
would.
in a lateral injury rather than a end injury, isn't it?
Yes, sir. Also, placement of an probably a ERCP stenting itself rules out the possibility of complete transaction of CBD.
Okay. Vishal, anything you want to?
Just one, I need one clarification. I think you said in your presentation, patient was admitted on 23rd of September, right?
Yes, sir. Yes, sir.
And he underwent lab coli on 12th of September.
Yes, sir.
So whether this ERCP or whatever endoscopy procedure, it was done after the admission because it was done on post of day 15.
Yes, sir. ARCP and intra-abdominal drain placement was done at our institute after his admission. He underwent a lap cholecystectomy elsewhere.
Okay, right. And second, you have said in DD, the bile leak. So I think when you are asked to enumerate the cause of bile leak, then you should not also miss the leak from the gallbladder bed, right? There may be Kapoor. So there may be, in terms of frequency of injury, you can describe, right? It may be cystic duct stump leak, maybe because of blowout, maybe because of multiple reasons. It may be lateral leak, or it may be leak from the gallbladder bed, duct of Lushka. So in terms of type of injury, it may be a type A injury, Strasbourg, or it may be type D injury. In both the
Yes, sir.
situation, after endoscopic procedure, endoscopic intervention, the output may decrease, right? So if I want you to summarize in terms of the uh, chronology or sequence of events, so what you can think of, what actually has happened during the entire period of less from the surgery. Just don't think of suppose you have seen this
Sir, your voice is breaking
the
up, sir.
patient has not underwent any intervention. I'm just saying, just think of that you have seen this patient at the time of admission before any endoscopic intervention. So, what comes in your mind? What has happened inside during the procedure?
Sir, since the intraoperative duration was not very prolonged, I would not think of a very complicated procedure. There must not have been many additions, so there is less chance of any misidentification of the cystic duct and the CBD. So probably I would consider cystic. Hello,
Hello?
Yeah, please.
I probably consider a cystic duct stump blowout firstly, followed by lateral injury and leak from a duct of Lushka. As Sir rightly said, duodenal injury is a little bit unlikely because the patient is presenting after a prolonged duration without any significant sepsis. So the patient is not in frank sepsis, so it's unlikely to have a concomitant hollow viscous injury. So I
Duodenal
would,
injury patient will not last for 2 weeks for you to come and the intervention. So at
yes,
least
sir.
that's
Yes, sir.
completely ruled out, I would think so, at
Yes,
this
sir.
stage.
So I would think of two or three possibilities. Firstly, the clip might have slipped due to any reason. Secondly, the clip might have slipped due to increased pressure, increased back pressure from a impacted distal CBD stone, which was missed intraoperatively or preoperatively. Third is a lateral
I
injury.
think better, can I interrupt? I think better to say what is the reason for leak and what is the cause of that leak. So if there is a leak from the cystic duct, irrespective of cause, whether it is some technical error or because of it is of underlying CBD stone. So there is a leak, type A leak. It is from cystic duct, or it may be from the gallbladder bed, or it may be some lateral injury. Right? Any other
Yes.
diagnosis you can think of?
Can you think of? If not, I think
No, sir. No, sir. No, sir.
okay. Vishal, if you don't have anything to add, I think we can proceed.
Now we can proceed, sir. We can proceed.
Yeah.
Yes, sir.
So tell me, Pranay, now.
On general physical examination, he is conscious, cooperative, and oriented to time, place, and person. He has a moderate build with no temporal hollowing or muscle wasting. His tongue is moist, and there is no evidence of petechiae or ecchymosis in the oral mucosa of the lower limbs. He has a BMI of 23.17 kg per meter square with no signs of liver cell failure. Pallor is present, icterus is present, and sclera is yellow, but the floor of tongue and skin of palms were normal. At presentation, his pulse were 106 per minute, regular, BP 110 by 70. He was febrile with a temperature of 100 degree Fahrenheit, a saturation of 98% on room air, with a respiratory rate of 21 per minute. He is currently a febrile with a pulse of 80 per minute, BP 120 by 80, temperature of 98 degree Fahrenheit with a respiratory rate of 14 per minute. In abdominal examination, on inspection, the abdomen is found to be mildly distended, umbilicus is central and inverted. Primary heel scars were present at the port sides. All quadrants were moving correspondingly and equally with respiration. No visible venous prominences, no visible peristalsis. Hernial orifices were normal. There was no fullness in the flanks. Percutaneous drain tube was present in the right upper quadrant, draining greenish bile. No excoriation or erythema was present at the drain site. On palpation, a diffuse, tender, firm lump in the right hypochondrium, about 7 centimeter to 5 centimeter in size, was present, which was not moving with respiration. It was non-pulsatile and disappeared on head raising and was not prominent in the knee elbow position. Other quadrants were soft and non-tender, and there was no organomegaly. On percussion, the liver dullness was at the fifth ICS with a liver span of 12 centimeter. No fluid thrill or shifting dullness were present. Bowel sounds were normal on auscultation. DRE showed and no normal anal tone with the finger stained with yellow stools. Other systemic examination were normal and non-contributing. Shall I summarize, sir?
No, I think you have mentioned this. I just want to add one point. Like when you're describing icterus, you don't have to really go that palm is not icteric or not, skin is icteric or not. I think just icterus present or not, that's good enough. Whether it's in the sclera or it's in. Obviously, when you're examining icterus, you are looking at the sclera only, not at the palm skin or anything. So don't have to be so elaborative about description of the icterus, where you found and where you did not find. Similarly, about the lump, if it is intra-abdominal lump, that's good enough. Obviously, nobody expects a parietal lump here that you have to mention it by saying, like knee elbow position and all those things. Those are okay for description. I mean, for bookish description is fine. But in practice, obviously, you don't do all that. So, it need not be so, particularly at this stage of your examination of your, when it's a DNB or MCH case presentation, we don't have to really look for all those to demonstrate that this is an intra-abdominal lump or is extra-abdominal lump. I mean, all those are superfluous. You have to basically present your case in relation to what you are presenting, in a sense, the patient's problem, rather than trying to be over emphatic on this lesser points like lump, icterus, etc. Carry on.
Yes.
So how do you proceed now? What is the current state of patient when you are examining or at this stage?
So currently he appears to have a controlled low output external biliary fistula with retained biliary entry continuity.
And how many days? How can you say there is a retained biliary entry continuity without
Sir,
having any imaging or anything finding
sir,
on
he has
that?
at least a partial retainment of biliary entry continuity as because he has no clay colored stools. He is he has no pruritus. Also, his as because as I have mentioned, his
No,
uterus is
we
not
can
that.
see the low output fistula. That is why you think it's the partial injury or is the biliary continuity is there. But biliary continuity, unless you have demonstrated it on imaging, you can't really say clinically that it's present.
Yes, sir.
Mm.
May
And
I
why you
interrupt?
have said it is a sorry, please continue, sir.
Yeah.
Pranoy,
What did
yes, sir.
you think the lump was?
This thing, I'm Dr. Obik. If say suppose there is a complete say cut off, there is a complete transaction of the duct, still patient can pass normal color stool.
Yes, sir. He can pass. It generally undergoes spontaneous internal fistulization,
Yeah.
causing uh, causing the patient to not have clay colored stools.
What did you think the abdominal lump was?
Sir, it might be phlegmon due to an inflammation. The
Phlegmon
bowel,
will not be palpable through the abdomen.
uh, basically, sir, he had an as per the history, he had an infected bilioma which was subsequently drained.
Yeah.
So
So
the
bilioma is
inflammation,
most likely.
yes, sir. So, but it has now been drained, but the lump is still palpable, sir.
That is possible if there is a thick wall of the collection. It takes some time to regress.
Yes, sir.
You said it is a control external biliary fistula, but in the presence of ongoing sepsis, I would not agree. PCD is there, it is draining, but there is a phlegmon, there is a lump, not necessarily because of phlegmon, there is an ongoing sepsis. So I would rather take it as a suspected uncontrolled fistula. There must be some collection inside, right? So I will not agree that it is a control external biliary fistula until unless you have ruled it out with a cross-sectional imaging.
Yes, sir.
With a controlled external biliary fistula, why would the patient is having fever even after a PCD placement?
Sir, his fever episode started abating after PCD placement. He had undergone a PCD placement on POD 12, and from POD 13, his intensity and frequency of fever episodes gradually reduced. He is currently having no fever and he is tolerating oral swell. He is also passing flatus motion. And on
No, but
clinical
I think
examination,
in your presentation you have said patient is having fever, if I
no,
am
sir,
not wrong.
he was having fever prior to the placement of PCD. He is currently febrile, sir, and his fever episode started subsiding after
Okay.
placement of this PCD.
Okay, what will you do next now?
Uh, Sir, since my professional diagnosis is a controlled low output external biliary fistula, he has already undergone a PCD uh, placement and an endoscopic procedure, which is most probably an ERCP. Also, the patient does not appear to be dehydrated. Clinically, he does not appear to be in sepsis. He is tolerating
No,
oral
we are not
swell.
asking for justification. I am just asking you what will you do next.
I would wait
I'm
for
not
a
asking why.
conservative management, sir. I would do a conservative management, keep a watchful waiting, repeat the counts and the LFTs at regular intervals, and wait for the external biliary fistula to close.
No, you don't have any imaging finding as of now unless you have a ERCP picture with you. Would you not like to see the biliary system at least at this stage?
Sir, I would
And if there
definitely
is
like
any
to.
residual collection or not?
I would definitely like to review the previous records, the ERCP findings as well. So based on
Yeah,
that,
that is what. If it is available to you, you would look for it. If it is not, then obviously you'll ask for some imaging finding because you would want to image the biliary system here,
yes, sir.
isn't it?
Yes, sir.
So have you done that?
Yes, sir, we have done that. May I
And
show it?
another thing, you said that the collection is still palpable. Could it be a unloculated collection and you have drained only one locule and not drained the other locule? Wouldn't you like a cross-sectional imaging as well at this stage?
Sir, cross-sectional imaging has also been done, sir. But if there had been a undrained collection, the patient might had been also getting fever episodes. But I would rule it out with a cross-sectional imaging, sir.
No, the point is, you said there is a phlegmonous mass or there is a mass palpable. Once you say there is a mass palpable, there has to be something inside. I mean, it can be a normal abdomen inside without any collection, without any lump, I mean, without any inflammatory mass or anything. So I think you need to image that as well.
Yes, sir, definitely, sir. May I show the investigation, sir? The imaging.
Yeah.
This was the CECT report, which was done
You don't have cards,
after.
CTPN,
Yes, sir.
CT
Yes, sir.
cards.
Yes, sir.
You show that report. You can come to that later.
Yeah, I think you should start with reviewing the old investigations, right? It is better to review the old even before the surgery. So what was the condition of the gallbladder before cholecystectomy? Whether
Sir,
it was
actually, I have
gallbladder or something else.
I have actually compiled the investigations in a single table pre-operatively as well as post-operatively.
Pranoy, you were asked a simple question, what will you do? You made a provisional diagnosis. So you have to, your answer should be that, sir, first I will like to confirm the diagnosis. Then only, you see, management has two components, no?
Yes, sir.
You investigate and then you treat. So you say that you and you already knew that endoscopic intervention has been done and which has helped. So you should have shown that the first thing, sir, I will like to review that endoscopic imaging.
Yeah, sir, I was.
And you will know the adjective, whether it is a cystic duct, a blowout, or whether it was a lateral injury. Then only you will proceed. I mean, it was not a very difficult. Just think and don't be in a hurry to answer. Just answer is a very normal thing. You will be. I am sure in your center you have seen enough number of these type of cases. So don't get flabbergasted. Just a simple question, Professor Ibrahimullah asked. Just a very simple question. You have complicated it. Just think what examiner wants to know and you answer.
Yes, sir. I will put up the slides that show the preoperative as well as the investigations after the admission. Shall I show?
Now, who is interested in? Already you have told that patient did not have any jaundice, his liver before. Nobody will do a cholecystectomy saying deranged LFT. So you just stick to in a case presentation to the first investigation which you will like to see, where or based on which your management is depends. You will proceed. So you see the ERCP picture first, then you ask for a ultrasound or a CT scan. Then you say, I am sure that this all must have been done. So you show in that sequence.
Okay, sir. This was the post-operative ultrasound, sir. It's mentioned here that the liver is enlarged, but there is no dilatation of the intrahepatic biliary radicals. There was approximately a 45 into 18 mm size subcapsular collection adjacent to segment 6 of the right lobe of liver with collection in the GB fossa. Surrounding omentum, mesentery and bowel loops were adhered to the GB fossa. The CBD diameter has not been specifically mentioned. Neither has there been any comment on presence of an intra CBD stone. But there as surrounding minimal pleural effusion on right side with basal consolidation. Following this, a CT scan was done at our institute. We can see the thin cut sections, non-contrast enhanced.
Your CT string is not visible. Those films are not visible.
Is it visible now, sir?
Yeah.
Yes, yes.
So in this video, we can see the non-enhanced, non-contrast face. He is having some amount of consolidation in the right lower lung zones. The liver appears to be normal in size with some amount of collection in segment 7 along with collection in the gallbladder fossa. We can see radiopaque small structures in the GV fossa. Probably these are the surgical clips placed post cholecystectomy. We can't see any gross dilatation of the CBD or the HBR, but neither there is any contrast leak from any bowel loop.
This is how many days postop?
This was done on 24th, sir. POD 12.
POD 12. Okay. So what's your impression after the CT scan?
Sir, I will.
What's the volume of this collection? I mean, to me, it doesn't look like a very major collection or a very big collection.
Yes, sir. I will.
And that
Just
too,
check the
having
volumes.
this amount of collection 12 days after surgery, probably, I'd be inclined to think what Dr. Vishal said, a subcapsular leak or a very minor leak from some duct somewhere.
So it has been mentioned that the gallbladder fossa collection is about 4.5 into 8 centimeter. The collection along segment 6 and 7 is about segment 7 is about 1.8 into 4.5 centimeter.
I mean, the impression you get looking at this picture, probably it will be a 20-30 ml size collection, not more than that. Isn't
Yes,
it?
sir. Yes, sir.
So,
Can you
this
put
amount of
contrast?
Yes, I
Contrast
put up the
in-
contrast. The walls of the collection are not being significantly enhanced, as also there is no significant dilatation of the CBD.
not CBD, intrahepatic dilatation. Okay, extrahepatic CBD also you can. Okay.
We can see also no significant collection in the pelvis or any of the paracolic gutters.
Why significant? There is no collection at all.
Yes, sir.
We can see, yeah. It's only confined to the subhepatic area, not
Yes,
the
sir.
GV fossa area. Okay, so what next after this?
Mm. So the drain collection should ideally be sent for culture and sensitivity to judge what antibiotics I can get. I will.
Well, that's okay. What I mean to say, after this CT scan, what the percutaneous drainage was done, isn't it?
Yes, sir.
So you have an imaging finding, I mean this biliary imaging findings,
Yes, sir.
MRCP, RCT or whatever.
Sir, after the CT scan, a percutaneous drain was placed. After the sepsis subsided, we did an ERCP that that showed a normal size CBD without any filling defects and a
Okay.
leak from the cystic duct stump. No stones were retrieved on Dormia basketing, and a 7 French plastic stent was placed in CBD.
So what was the
I'll
drain
just one
output
question to ask
at the
you.
time of
Well,
ERCP?
So it was about 150 ml. Sir.
Please, sir.
yeah, no, I was just asking you,
Pranav,
like this.
can I?
Yeah, Vishal, okay, you finish, Vishal. After that, I'll.
Yes, I'm just suggesting him that because I think he is presenting the case at two different point of time. He has presented when the all the interventions has been done, but now he is presenting imaging and then he is going I think to and fro at different time at the time of admission and then once the all the investigations have been done. I think you better have to decide that when you first saw the patient, when the patient was first admitted with the problems, right, then
Yes,
it
sir.
would be a better thing to think of that patient in terms of the prospective management. Now everything has been done and then it becomes difficult to actually go back and forth in terms of management decision point and uh, discussion point of view. So even for the future, I think you have to decide one particular point of time when you have to actually decide on which point of time you have to take the history and examination. Suppose you have seen this patient, once all the investigations and interventions have been done, then all those become part of your treatment history to make the situation very clear.
Yes, sir.
Sir, please.
Okay. I said if you have the primary treating physician or surgeon, whoever, and would you do ERCP straight away, or would you like to do any imaging study beforehand, then only decide that whether we should go for ERCP or not?
Sir,
I mean,
ARC,
straightforward.
I would like
Is
to do an
MRCP
image. I would like
would
to
you
do
have
a
done
cross.
MRCP before? Yes.
Sir, I would like to do a cross-sectional imaging, preferably a CT. Confirm that there are no residual undrained collection. Confirm that there is a maintenance of biliary entry continuity, and then only I would decide upon an ERCP or an MRCP. Sir.
Biliary entry continuity you won't know from CT scan unless you have some other test. Tell me what else would you have done to confirm there is biliary entry continuity if all the investigation are available, facilities are available with you. CT scan will not tell you. I mean, might give you an idea, but obviously that's not the ideal investigation to tell you whether there is biliary entry continuity or not. What else would have been helpful at this stage?
I would
Any
like to
dynamic
see.
study, dynamic imaging study.
Since we have since a drain is already been placed, I will attempt to do a fistula ground.
What is the imaging modality to confirm conclusively that there is bilioenteric continuity or not?
MRCP or a ERCP, sir.
Any
Preferably an
dynamic
MRCP.
study. I'm giving you a hint. MRCP is not a dynamic study. Scintigraphy, what about?
Head scan, sir. Head scan.
Yeah, biliary scintigraphy. That is one study that will conclusively tell you if there is bilioenteric continuity or not. So, okay, it's not available with you. So, would you have done MRCP before planning ERCP or straight away will go for ERCP?
Sir, ideally,
I would certainly want to have a preoperative biliary imaging in the form of MRCP. Then I could have decided whether to go for ERCP
yes,
or
sir.
not.
Yes, sir.
Okay.
Ideally, an MRCP should be done prior to an ERCP. Sir.
Yes. Unless cost is a limiting factor. So you don't have MRCP beforehand?
No, sir. The MRCP was not done in these patients.
Okay. Supposing you do this ERCP and it's not demonstrating any leak here, it has, but supposing it has not, what would you surmise in that case?
So it might be a minor leak, or it might also be leaking from a system that is not connected to the intrahepatic biliary system.
Exactly, that is what I wanted. So what are the situations where it can happen?
So a type C, Strasbourg type C injury, where there is injury to a aberrantly placed abnormally low-lying RPSD.
Okay. So when you are doing this ERCP, what are the things you look for specifically in such a situation?
Sir, when I will do the ERCP, I would look for any growth at the ampulla. After opacification, cannulation and opacification.
Again, additional things which will put you in trouble. Why are you looking at ampullary tumor now in this patient? I'm talking in this particular patient, what are the things you look for in the ERCP when you're doing an ERCP?
Dilatation or diameter of the CBD, any cutoff, any leak which is evident,
and stone, any obstruction, any stone,
any
most important. And you try to fill in all the systems. I mean, try to visualize if all the segmental ducts or everything is.
Yes, sir. They are all. I will visualize at least the first and the second order bile duct system.
Yeah. Okay. So what now in this patient?
Sir, I would like to go for a wait and watch approach, and I would wait till the external biliary fistula spontaneously closes. I'd follow up with him with regular CBCs and LFTs, and once his fistula closes completely, then only I will think of removing the ERCP step.
You expect this fistula to close or not?
Yes, sir.
It would definitely close.
So what is the fistula output trend after this endoscopic intervention?
So it has reduced from 150 ml to 30 ml.
So how long will you keep this stent? So suppose this fistula closes in next 2 days, right? Fistula is dried up in next 2 days. So will you take out the stent after 4 or 5 days, or will you wait for some more time?
No, sir. I would wait for at least 3 to 4 months prior to taking out the stents.
3 to 4 months. Sure.
Yes, sir.
6 weeks would be a minimum standard time, I think. You should mention 4 to 6 weeks, not 3 to 4 months. Okay.
So what are the indications of endoscopic intervention in this patient? Suppose if you have a collection bilioma, you have you got the PCD done, there is a controlled external biliary fistula, sepsis is resolving. So what are the different indications of endoscopic intervention?
In this patient, I would put a ERCP to accelerate fistula closure, sir.
All the patients, suppose this patient has just 50 ml per day fistula output or 100 ml, 150. Is there any cutoff or any particular indication?
Sir, if we are noticing a definite decrease in the drain output without even an endoscopic intervention, we can wait till the spontaneous closure of fistula, because ultimately it should be closed in at least probably in 6 to 8 weeks. If you want to accelerate the fistula closure rate, we might go for an ERCP and a stent placement.
What do you mean by to accelerate the healing? It may be a very subjective thing. For you, it may be with the 100 ml. For me, it may be with 50 ml. Patient wants even with the 10 ml.
So till the drain output completely reduces to nil, sir.
So regarding the accelerating the healing, you have said just to accelerate the fistula to close, you have to go for the endoscopic intervention. So it becomes very subjective. Patient wants fistula to close within a day, even with 20 ml, 30 ml. So will you advise ERCP in this situation? And second question, what is the absolute indication for endoscopic intervention with leak?
One would be an ascending cholangitis, sir.
More common?
Suspicion of a retained CBD stone.
Yeah, suspected or confirmed. If there is a stone, it's very high likelihood that it will not close spontaneously. You need to decompress it or take out the stone.
Yes, sir. So regarding the spontaneous closure, sir, I'm not exactly sure about the answers.
No, without ERCP, could you have managed this patient? I mean, it's impossible.
Yes, sir.
I suppose you drain the collection and do imaging MRCP and there is continuity and this fistula output is not very high. 100 ml on day 1, day 2 or the first day of this thing is not a very high output fistula. You'll have to wait for about 1 week or so. Look at the trend if the fistula is closing.
Yes, sir. Yes.
And then obviously you don't have to do ARCP and stenting or anything. If it's a high output fistula, then certainly after waiting for 3 to 4 days, you get an impression that this is a high output fistula. You need to expedite its closure. And then obviously you subject this patient to ERCP. So I think with the MRCP in the scenario, it's very unlikely that you would go directly for ERCP in these patients and straight away, unless the patient belongs to a medical gastroenterologist. Also. Okay, I think this patient, that's the discussion possibly we can have. Vishal, anything you want to?
Just
May I
last
ask
thing.
something?
Yeah.
Yeah, so if this was a complete biliary stricture, that is a type E type of Strasbourg stricture, in which case would you opt for an endoscopic intervention and in which case would you opt for a operative intervention?
So type E strictures, ERCP, I would try with an ERCP and stenting in low strictures, sir, which are pretty little bit far away from the island, like type E1 for an operative inter, because if it the stricture is close to the island, ERCP won't be of much help. I would preferably go for an operative.
What are the indications for intervention, both endoscopic and operative?
Sir, formation of a benign biliary stricture post closure of an external biliary fistula. We can go
How
for
long would
either,
you like to follow up the patient?
at least for about 3 to 6 months, sir.
It's closer to 2 years because you can get very late fistulas. Within 6 months, you may get in a stricture that is already forming. You might get it very early in 3 to 6 months. But you should. It is better to observe asymptomatic patients for a period of 2 years, doing 3 monthly follow-up, and do the alkaline phosphatase and LFT tests whenever the patient visits you. You don't need to do an MRCP.
Yes, sir.
So what is the final diagnosis in this case?
Finally, we have a type A post cholecystectomy bile duct injury, post PCD and ERCP stent placement.
Okay. What are the long-term consequences of such complication? Do you think this type A complication, type A bile duct injury, is just a minor thing? There is no problem in terms of long-term. Patient asks you, should I continue to come to you every year, every 6 months, for 2 to 3 years, or Just
So,
there is no need after stent removal.
so in the majority of patients, this should pass off uneventfully. However, some patients can have a late occurring stricture because of diathermy injury at the cystic.
No, no, no. In this case, in this particular type A injury, do you think
Uh,
that some of these patients will continue to evolve into some major structure, maybe type E1? Is there any
sir,
possibility?
it may be possible, sir, because of diathermy injury near the hilum.
But
That might
diathermy
present a.
injury near the hilum will not manifest after many, many years. After it has already initially manifested as type A injury.
In this patient, it should be uneventful, sir. But
So there
we
is
need.
no possibility of evolving into some major structure later on.
Uh, there is a possibility, sir.
How your diagnosis was ultimately cystic duct stain, cystic duct blowout. What will happen to it now?
If the patient, due to biliary stasis, develops CBD stone, it might the cystic duct blowout might recur with a bile leaks.
You think so? That has already swelled.
Say the patient develops later CBD stone.
There's a very far-fetched thing. Not necessarily you have to answer all the questions. Some region has to be. See, if you are presenting this particular case, Professor Rahulullah told you earlier also. We are not testing your theoretical knowledge. That will you have already been tested in theory in an exam. Here you are presenting this particular case. This is a case of cystic stump blowout, and the cystic stump blowout that probably that clips have got dislodged, or the stone ERCP has made it clear there was no stone to the CBD. So
So in
now that thing has shriveled. So why the now after 2 years what will happen? You mean
no, sir.
that stump leftover stump will again blow out? That's a very far-fetched thing.
In the near future, sir, after the ERCP stent has been placed, the stent might slip or it might get blocked. The stent might dislodge or it might get blocked. In that case, the leak might recur, sir.
No, it doesn't happen that way. Once the leak has stopped, I don't think it will again reopen unless there is some pressure building up downstream. So only thing in the follow-up, okay, there is a remote possibility of developing stricture at that site because there is a bile leak and bile obviously induces fibrosis and all that. And plus, you may say this is a cystic duct leak, but this could be a small lateral leak as well in that cystic duct region. It's difficult to really say unless you are seeing a very clear cystic duct stump, which is opening up. So there's a distinct possibility of having a stricture. I mean, there's distant possibility patient. Otherwise, I think he'll have an uneventful recovery. 4 to 6 weeks later, he removed the stent. That's all, and call him for a follow-up 6 months or 1 year later. Have a LFT done if it's completely asymptomatic. Just LFT done, and that should be the follow-up to my mind.
Yes, sir.
Okay. I think we need to close. It's 10 o'clock now.
Yes, sir.
So, right. Thank you, Pranay.
Okay. Thank you.
Thank you, sir. Thank you, Ibrahim.
Thank you.
Thank you, sir.